Dear friends, along with Dr. Shivakumar, we welcome you all to this important session in which Dr. Kumar is going to speak. As per the old program, we said that now the topic is voice surgery and all this. My encounter with this gentleman, Dr. Kumar, is PG examination. Within a few hours, we could assess the mettle of this gentleman. He was wonderful in his performance, the exam, and soon he came out with 5 points. After that, he has taken laryngology as his second love, or the first love. And as somebody had commented, he is now designated as the father of laryngology in our state. And he is internationally known, and we are proud of him. And in the next few minutes, he is going to talk on the voice surgery and overview. From the, I think probably from the history onwards to the latest sophisticated techniques. Over to Dr. Kumar.
Thank you, sir, for those kind words. Now, we are out of time, and I think the time can also be cut short from 14 to 30 minutes. So, some of the clips I will just show. So, what exactly? Most of the you ask me about now is a very important topic in ENT now. Actually, it is not a subspecialty of super specialty of hair, super specialty of ENT, but it is a super specialty of laryngology. From the ENT, you go to the laryngology, and laryngology has got so many branches like airway tract disorders, laser laryngology, pediatric laryngology, swallowing disorders, and phonosurgery. And phonosurgery, because of its natural vocalist characters, it has attracted the attention of many people. So, in this short lecture, I will try to say what are the different techniques or what are the types of phonosurgery, and if I get time, some comments on the evolution of phonosurgery. Now, this picture was probably shown by Dr.Murali. This is MOV004, who gave below with the direct plus, gave the definition of phonosurgery. So, according to their definition, any surgery done to improve, alter, or regain the voice is phonosurgery. So, that simply means that phonosurgery is not nothing new. It has been there for quite a long time. A properly done vocal cord voice extraction was definitely a phonosurgery. A properly done vocal nodule, a properly done vocals, they all were phonosurgery. But phonosurgery got prominence because of the contribution from the other great Japanese, Ishiki. Because thyroplasty looks stunning. The thing was that they were under local anesthesia, and the results were not at the British like state activity, highly result-oriented surgery. That is why suddenly there is a surge in the interest of phonosurgery. Otherwise, definitely phonosurgery was always great. So, regarding the microsurgery technique, has definitely improved related to the instrument, the technique, the anesthesia, everything. Now, so, really, if phonosurgery, if the definition, if you go by the definition, if phonosurgery is any surgery done to improve, alter, or regain the voice. So they have got voice, not phonation. So that's a problem. Now, as of now, every surgery you talk about it, phonosurgery is on the vocal cord or on the phonation mechanism alone. This I want to reiterate again and again. Resonance is a very, very important part. And still we don't understand resonance that much, and we don't understand how we can surgically manipulate the resonance system. Actually, that should be that is the future of the phonosurgery. When we can change the resonance, we can actually improve the surgery or even make the surgery bad. One simple example is tonsillectomy. So when you do a tonsillectomy in a normal, in an ordinary level, like conversational voice user, the effects are not very great. But suppose Aishwaraj comes and he has got a very unlikely in this age, but suppose you want to do tonsillectomy. And I will never do that because tonsillectomy will produce definite subtle resonance changes, and for an established singer that can be very problematic. As Swati was telling in the morning, when Mohanlal underwent endoscopic nasal surgery for the removal of the polyps. He had an extensive test done by Dr. Murali. Surgery was excellent. Dr. Murali removed the entire polyps. But his residency, that was his normal residence, but Keralites were not familiar with that voice, so he didn't accept. He told that this is bad voice, this is not Mohanlal's voice. So that is why the time of Kalapani, when Mohanlal was dubbing for that voice didn't look normal at all. Luckily, because polyp is returning in Britain, now Mohanlal is back and has got that normal voice again. Now, so we will classify broadly, still the majority of the work will be on the surgery of phonation, and then a small talk on the surgery of resonance. So, on the surgery of phonation, we can classify them into the microlaryngeal surgery, which has been always there. The laryngeal framework surgery is something relatively new, added by the legendary MOV004. Injection laryngoplasty is still new, and the newer techniques in injection laryngoplasty is evolving. And of course, voice rehabilitation after laryngeal. So, they all are part of the surgery of the phonation. This was already shown by Dr.Murali. You can see that the Durano model, this is the cover, this is the body, and this is the transition, the vocal ligament. Now, over the last few years, the concept of vocal ligament has gained so much of importance to the point that now vocal cord looks so sacred. Surgeons, now every phonosurgery, surgeons go on telling the speakers, go on telling that vocal ligament is sacred, vocal. So, with the result that now surgeons become very afraid. You need to be very afraid of the vocal ligament. You can touch, you can use sharp scissors to cut it, but don't damage it, don't cut with a blunt instrument. If you are irritating it, you will create microplastic polypus. But you can certainly use a very sharp scissors if you want to separate the lesion from the vocal ligament. Now, this is the principle of phonomicrosurgery or microlaryngeal surgery. If you adhere to these 4 principles of phonosurgery, we can reasonably guarantee say that you are not going to damage your voice. The improvement you may not be guaranteeing how much percentage. But remember, don't touch the medial margin as far as possible. So do superior chordotomy and preservation of the vocal ligament. Try to dissect the vocal ligament away from the disease and preservation of as much normal tissue as possible. It is just like FES. Before FES, when ethmoidectomy was being done, including not only the polypoidal tissue, but the normal tissue also was removed. Now, with the FES, you remove the excision of the normal tissue is very little. So, similarly, in larynx, you don't remove excise of mucosa and vessel, and ultimately at the end of the operation, you try to redrain the mucosa if possible. That should be possible, not if possible. Most of the time, it will be possible. And use of tissue glue and use of sutures, both I have used. But I think most of the time they are warranted. If you well undermine and redrain it, it should be okay. Now, you must have heard a lot about the microflap. This is actually, I believe that this is a little bit of too much of hair splitting. Now, what exactly is medial microflap? In condition like vocal nodule, you make the incision as close to the medial margin as possible. But still, it is on the superior surface. While in a big radius or a cyst, you make the incision far too lateral. So this is the lateral microflap and medial microflap. I think too much must be made of this microflap technique, with the result that I have seen people attempting to excise the vocal nodule, elevating the trying to elevate the mucosa. It's not really needed actually. Only if there is redundant cover, you need to elevate the flap and excise it. Otherwise, you can actually trim off anything bulging beyond the medial margin. You can actually excise because you can cover the mucosa. But if it is a cyst, it is far too lateral, then you may have to elevate. So that is about the microflap. Now, recently, Gray produced a landmark article on microflap. This is very significant. So he says that between the mucosa and the vocal ligament, there are anchoring fibers. This is a landmark study. So he says that this amount of the anchoring fibers is genetically determined. The amount of fibers I have is different from what you have now. So people who have got less number of this anchoring fibers in the radial space are likely to develop outpouchings of the radial space more easily. In other words, they are likely to develop vocal nodules and vocal cord polyps. So that is why we see people who are doing vocal strain almost same amount, but some people develop vocal nodule, some people may not develop. So this could be the fact. Now, based on Gray's study, Robert Sutherland is probably the founder father of the professional voice care. We can tell that it's another super program phonosurgery. So Sutherland says that doing too much of dissection with the micro, medial and lateral flap is not really correct. And he has got a point, because even then we have got perfect microflap techniques. Sometimes patients develop long time to retain the normal voice. Even after a few weeks, even after 6 months, sometimes it takes for the patient to develop a normal voice. Because when you do the stroboscopy, there are not much of mucosal layer. So Sutherland say that on the evidence of Gray study, is that if you are doing too much of flap dissection, you are cutting the anchoring fibers. So he advised that don't do too much of dissection. So it is like what he was telling. You are coming back to cycle again. Now he said that don't cut too much, make a small flap. Even if you can't elevate the mucosa from the most medial margin, don't worry about it, you just cut it. Because if you are trying to elevate a flap from a nearly impossible thing like a vocal nodule, you may be creating more damage than good. But in a lateral case, where there is a cyst, where there is a sulcus, where there is a Rayleigh space, there is definitely a road for flap. But very medial microflap is highly questionable. Whether it is needed is highly questionable. So this is very important new concept now. Now you know that you all are familiar with the microscope, which gives reasonably good magnification. But now with the advent of telelaryngoscope, thanks to the invention of Carl Schurz company, now we have got this operating video laryngoscope with the telelaryngoscope. This is a 15-degree telescope. I'm sure that now most of you have seen it. And this year I think probably if take the population ratio, I think Kerala has got the highest number of operating video laryngoscope in the whole country, because I think voice awareness is very good in Kerala. So this is a telescope, 15-degree telescope, which gives tremendous magnification. You can look at the audio with the monitor just like you are doing the press. Your neck is far safer and no tissue is coming in between the vocal, in between the scope and the surgeon. These are the basic set of instruments. Again, note the significant difference. The cup forceps is now out because cup forceps has got a curvilinear margin. So when you catch hold of the medial margin, chances are that you may create a non-linear medial margin or vocal cords. Now we have got a triangular plain saucer forceps or the basket forceps, which has got a catching margin very linear. So this is the right and left, and this is the workhorse of the microlaryngeal surgery. This is the flap elevator. This is the upcutting system. This again I have told many places. If the management has got a lot of money, you can buy upcutting systems, downcutting systems, right cutting systems, left cutting systems, and straight cutting systems. But management say that I can buy only one system by upcutting systems. You require only that system. 45-degree upcutting systems is more than good for most of the microlaryngeal work. This is a sickle knife, just like the nasal sickle knife. But now I have abandoned this. The problem is that sickle knife after 3, 5, 6 operations become very branched. And when you incise with the sickle knife, you sometimes create tearing of the mucosa. So I have abandoned this altogether. So what I do then, I have asked Krishna Gudya, he has done from Shobha, he has done a very good, easy laryngeal BP hand. Roadburger hand, which easily number 15 and number 11 plate can be easily connected. So this possible, you can put a very sharp cut. So I don't use it now. Same is the case with scissors. It is better to use something like, most of the time you can use a scissors for only 5 cases, 6 cases, then it becomes blank. This is a terrific equipment, honestly. Lindholm vocal cord retractor, with which you can expand or retract the ventricle so that you can see the whole of the larynx, the whole of the upper surface of the vocal cord, and also the subglottis if needed. And you can also have a suction diaphragm. This is the basic set. If you are got, if the budget is better, you can have more. I don't take the case, but I will go this. This is, I will show this case first. This is a tumor dissection. Previously, we were told that if you take a biopsy, then you see a vocal cord growth, you take a biopsy, at multiple sites and send for the report and come back. And that is logically correct because of First of all, the patient came to you because of morsels. If you are retaining part of the tissue, the morsels will not go away. Second part is that you might exercise part of the growth. It might come back as no evidence of malignancy, but that simply doesn't mean that at other sites there will no malignancy. So now current concept is that if there is a papillomavirus or a proliferative growth on the vocal bone, you have to first inject, elevate it from the vocal ligament and excise as completely as possible. You can see my technique of reiterating. Now at the end of the surgery, hardly there is just a small shallow groove-like thing. So all papillomavirus, all suspected growth should be excised in out of rather than taken a biopsy alone. Biopsy alone has got these two problems. Because patient mainly came here for the voice problem. So he is worried about the cancer, that is all right, but
Please show the previous one. Very important.
which one?
Others.
Other two. Yeah. This is the cyst surgery. Now, technically the most difficult. And in my experience, I have seen that most of the time when superior codotomy does, the cyst breaks. The chance of cyst breaking is very, very high because most of them are inward. You may be able to excise in total, maybe around 20% of cases or even less. But don't worry, the thing is that avoid one mistake. What generally one does is that when you accidentally burst a cyst, immediately surgeon puts the suction. That is a big mistake. If you put the suction on the opened up cyst, then you won't see the cyst wall. So don't put the suction there. Don't get panicked just because the cyst break. Just use the cleansers or the corresponding cleansers with that and catch along with that burst material. Most of the time you will be able to catch hold of the cyst and you can actually easily oppress away with blood dissection. No, this is a sharp resection, it came out normally, but I'm telling that most of the time, the chance is high that it may break. But don't apply suction immediately. If you apply the suction, then you will not see the cyst fall again. It is very, very thin bone. But you catch hold with that thick circulation. And again, the same technique at the end of the surgery, if there is a little bit of there is no mucosal damage, loss here, if there is a mucosal loss, you can always little bit undermine, but again, if what Robert Sutcliffe says is correct, then you shouldn't undermine too much also. So this is another vocal cord fixation. Here again, you can, but I am not going to preserve the mucosa here because it is already bulging well medial to the vocal ligament, medial margin of the vocal cord. So there is no point in actually keeping too much of mucosa. If there is very much redundant mucosa, you are justified in elevating it. So cyst you need to elevate, sulcus you need to elevate, raising edema you need to elevate. Otherwise, you can actually exercise a little bit of mucus, with overlying mucosa, and you can still get a very sharp medial margin. I think I will do it little bit now. We go to the laryngeal framework surgery. You all know this is MOV004 who changed the concept. He's a plastic surgeon by training, but he had training in laryngology also. Brilliant brain, he conceived the idea of changing the pitch and the depth and everything of the vocal. So, I will use the descriptive tape first and I will use the tape used by Ishiki later. Now, medialization thyroplasty is the commonest technique, commonest thyroplasty. Ishiki called it type 1 thyroplasty. So, indication can be classified told in a single sentence where the vocal cords don't or attack loosely or they don't attack properly. So any condition where the vocal cord adduction is too loose, you can do the medialization thyroplasty. So it is unilateral vocal cord palsy is a commonest condition. You can get sulcus vocalis, you can get pros bilateral, you can get myasthenia gravis. All of them you do bilateral in unilateral vocal cord palsy. You do the unilateral. So that's the commonest surgery, thyroplasty in Shiki's group. So you know the technique, most probably will be demonstrated, so I will not be going to the detail. There are techniques how you mark the window, you remove the window. The current concept is that you remove the window, you don't keep the cartilage there, you keep the internal perichondrium intact. Again, don't go there. If you accidentally cut the internal perichondrium, nothing is going to happen. Because there are surgeons who intentionally cut, especially temporarily cuts the internal perichondrium intentionally, saying that in long-standing paralysis, the internal perichondrium is too stiff. So unless you cut it and make it pliable, the process will not medialize it. So you can get a different types of cases. This is a unilateral. I have a lot of cases. This is a unilateral case who had a so he was trying to compensate his unilateral vocal palsy with a high pitch voice. That is why he has got a high pitch voice. So this is before surgery, not after surgery. There is a mistake.
1, 2, 3, 4, 5, 6, 7, 1, 2, 3.
So what he was doing was that
9, 10,
extralaryngeal muscle, so that the larynx was high in the neck and it was compensated. That is why he was having a high pitch voice. Now this is a lady who had myasthenia gravis and had a very bad voice. So I have to do a bilateral thyroplasty. She is a patient from Sri Lanka. You can see the difference.
5, 6.
Even though she had bilateral paralysis, it was mainly on adduction. She didn't have any problem with the abduction, so I could safely do the bilateral thyroplasty. If the abduction was also affected, then I would not have died to do that surgery. She never had any problem with the abduction, so I went on with the surgery. Now, midline lateralization or type 2 thyroplasty. So here indication is opposite. In type 1, the indication was that vocal cords were meeting too loosely. Here, the indication is that vocal cords are meeting too tightly. So the classical, actually the only case will be adductor spasmodic dystonia, where there will be lots of hyperadduction of the vocal cord. Even the maxillary and adduction will be there, and so the vocal cords are adducting too much against each other. The technique will be very simple. I orient you, this is the superior thyroid notch, this is the inferior thyroid notch. You split open the midline just like you do in the laryngophyta, but you don't open up the internal perichondrium. You just stop short of the internal perichondrium and keep on pulling the area apart. At one particular point, the spasm will disappear. Generally, it is 4 to 5 millimeter, and you measure that distance and keep a suitably wide sylastic processes in that position permanently fixed, so that the vocal cords won't get hyperadducted again. This is a good surgery, but it will never be as good as botulinum toxin. This is a patient, Joey knows. He was a patient who had treatment with botulinum toxin, and he actually improved with botulinum toxin. But the problem was that he is from Jharkhand, Ranchi, so he couldn't come every 6 months. So then I had to do 1, 2, 3. He had actually addition to this, he had also some severe muscle tension dystonia, for which he had to undergo a little bit of voice therapy also after that. Actually, in fact, he stayed in Trivandrum for nearly 3 months for the further training. You can see the severe spasm.
3, 4, 5.
See, the voice is much better, but listen, it is really breathing, and everybody will slightly come down because you are forcibly separating the vocal cord. Now the third surgery is relaxing thyroplasty, or otherwise known as type 3 thyroplasty. Again, there is only one indication, buberphonia, but I request you to stress more on here. Don't trust put into voice therapy. It is very easy to jump into this surgery because this is an easy surgery and it is probably the most dramatic surgery in ENT. Because patients, he speaks like that all of a sudden on the table he starts speaking really low pitch sound. It is highly tempting to do this surgery, but 90% of the patients do very well with voice therapy. So only if they are not responding to voice therapy, you go for treatment from a cervical correction. Otherwise, it is unfair because I remember that I had demonstrated this surgery once, and then 2-3 years later I had a conference then I was shocked to see 18-year-old boy, 19-year-old boy who had already undergone dietary therapy. That was so bad because none of them could develop. They were easily corrected. So the principle is simple. You make 2 cuts on either side of the midline, 5 mm from the midline, again only up to the internal pericondyum. Make this segment totally free, push it in, and how much low pitch you want, at that particular point you loosely fix it with rolling. You can see before the surgery the vocal cord is very tense, after the surgery the vocal cord is lax. Don't make it too lax, the voice will be bad. So, and it generally, I would ask something like stapedectomy. This is a very, very dramatic surgery. Water table patients who is in suddenly very sound.
6, 7, 8, 9, 10, 1, 2, 3, 4, 5, 6, 7, 8, 9,
So he's a 35-year-old man and he was responding to the voice therapy. Now you can listen to much low pitch, bass voice, very tough.
7, 8, 9, 10, 1.
Now, tension in thyroplasty or type 4 thyroplasty or usually called thyroid approximation. Indications are androphonia and SLN palsy, especially bilaterally. This is a sign of SLN palsy. The right area-epiglottic fold is transverse. Normally the area-epiglottic fold should be anteroposterior. This is one sign, but most of the unilateral SLN palsies don't require any cervical junction. They generally compensate. Till today, I have been done a type 2 thyroplasty for anteroplasty. While in Ireland, you see this young lady here, such a low pitch, and she is doing voice therapy and doing very well. I have been done a type 4 thyroplasty for an androphonia till now. While in Ireland, after type 1 thyroplasty, this was the commonest surgery. I had great expectation when I came back to Kerala. Probably somebody like Mani Vishwanath will come to me. But till today, no patient there with a low pitch voice, a lady has come. I think androphonia is not very common in our country, while puberphonia is rampant. So the technique is again very simple surgery. You take suture through the tricot onto the thyroid and tie over the xylostic bolster. Tricot is tough, you don't require xylostic bolster, but thyroid you require xylostic bolster, otherwise it will cut through. You will remember probably while the failure of previous suture codopexy for bilateral cord palsy. Most of the time, the failure of suture codopexy is that the suture cuts through the thyroid cartilage later. Because thyroid is not very good in preventing the flow input. While tricot will stand. So whenever you tie over the thyroid, you have these xylostic bolsters. Finally, arytenoid rotation. So if type 3 thyroplasty is the most dramatic surgery in your at least gynecology, this is technically the most challenging and the most difficult surgery you can actually ever conceive, because this is to be done in a under local anesthesia. You are dealing with an area where there is internal jugular vein, carotid artery, pyloriform fossa, so dangerous a surgery, and if it is a full neck male, then you have the worst case probably. So what are the indications? So it is done only in unilateral vocal cord palsy, not in sulcus vocalis, nothing like that. So there has to be a big posterior phonetic vertical level infometallurgy and very poor LTD, maybe less than 5 seconds or 4 seconds. So the concept is very simple, but it is brilliant. It is difficult to put into practice. You take a suture through the muscular forces and anchor it anteriorly in the direction of the lateral tripod node. With the result that the vocal process will rotate medially. So these are the two patients. Again, they are from out. This is a patient, Mr. Bajaj. He is from Bihar actually. So she had already undergone a type 1 thyroplasty, but there was no improvement.
1.
You can see the difference now. The breathless is now gone. And
6, 7, 8, 9, 10.
again another patient. This is he's a Sri Lankan. Again, he underwent a type 1 thyroplasty. Now that again didn't improve the voice. You can see that the quality of the voice is still healthy. You can see the difference now. Now we come to the injection laryngoplasty. This is something new. Paraglottic patch injection. Previously we were injecting Teflon. Now Teflon is almost definitely bad because it produces granuloma. So paraglottic patch injection is a good technique, especially for small phonatria. So you can select, use certain unilateral vocal cord palsy, sulcus vocalis, and prosbylarynx. One other advantage is that if you are familiar with this technique, you feel far more confident in doing hypothyroplasty because even if it fails, you have got a second weapon in your hand. You can always correct a small gap. Suppose you did a thyroplasty, due to the edema at that time you probably undercorrected. Later patient has got a gap, you can always inject it back. So technique is ideally you can collect the fat from the anterior abdominal wall using a liposuction technique and using an 18 gauge needle. I actually started using with a 18 gauge scarpine needle. If there are tomorrow cases, we can show that. But now stores has brought up that brilliant equipment. It is almost like pruning syringe. With each stroke, only 4 and 5 cc of fat will go. Only problem is that it is very, very expensive. Right now, it costs nearly 90,000 rupees. And again, this was a very big man, 150 gauges, and he was so afraid of local anesthesia. He won't come for the thyroplasty. He will even cry at injection. So I have to only, I could only do an injection laryngoplasty.
One, two, three, four, five, six, seven, eight,
over
nine,
it, more than roughly around 30% of the fat. But whatever absorption happens, generally happens in the first 3 months. Now we go to the botulinum toxin injection. So this is a standard treatment for spasmodic dysphonia, for attention and attention. This is a lady who had a road traffic accident, and it has been described that spasmodic dysphonia can also occur secondary to diffuse brain injury. So she was a teacher, and she lost her voice. Very bad voice. She is a high-profile teacher, and she is actually now is going after a court case claiming, I think somewhere around 5 crore rupees. I don't know how much they will give. She is claiming a tremendous amount. But you can see now with the botulinum toxin, he has now started back teaching again. The technique of injection, and again I think I will quickly repeat this because we are even demonstrating it tomorrow. That is what I am giving is a local anesthesia, 4% local anesthesia, so that the patient doesn't cope when I am doing the injection. So you need a special needle, Botox needle. The technique is you go through the trichothyroid space. Once you enter the larynx, tip the needle upward and laterally 30 degrees and keep on advancing. And then look at the EMG monitor. If it is in the EMG monitor, then patient phonetic, you can see big action potential content that it is in the needle, it is in the thyroid electrode. You can connect the botulinum toxin and injection. So you already saw that patient and the patient. This is probably one of the worst spasmodic dysphonia I have seen. Okay. We already had undergone like 2 thyroplasty cells when did it improve? You can see even the alternate speaking is a lot of voice problem. Where you are? How long have you been having this problem?
Past 2 years.
Is it getting any worse? When was the operation started?
2003.
Now this is after Botox injection. Oh, sorry. Okay, really, then he had actually very good improvement. Now, do I need to go to this? In fact, we are there. So I think that you are familiar with these topics. So I probably conclude the topic and talk to now for the time being. and the remaining resonance disorders controlled properly. When we have got a intertechnical class being case tomorrow, so we can discuss that during that time.
Hello. Dr. Jaykumar is wonderfully delivered his lecture regarding various techniques of this cytoplastic. It's very useful for his postgraduates and everything. Demonstrating the much depth of the microlaryngeal surgery, which is so far we have not seen. It's very useful for us to understand. Thank you.
Thank you, Jayakumar, for the excellent display of the features of the voice, and especially when you have dealt with the ordinary, usual surgery, like removal of body, cyst and all. You have highlighted your practical points and features. That was very useful. Thank you very much.
Thank you, sir. We now request Dr. Subhash, Senior Consultant PhD Surgeon, Vadodara, to hand over moment to Dr. Jefferson, the Doctor of Love and Consultation. Please, sir.
Attention delegates,